All right, I'm going to introduce our first guest speaker. A lot of you already know this lovely young man. I've had the pleasure of working with him for a number of years as well, and he is so patient-focused and just genuinely a sweetheart. So he's an associate professor at the University of Alberta and medical director at the Northern Alberta Blood and Marrow Transplant Program, which includes cell therapy. He helps in the care of people living with myeloma, amyloid, and plasma cell diseases in Edmonton and in Northern Alberta. And so I would like everybody, please give a warm welcome to Dr. Sandhu.
Thank you, Lorelei. Thank you for the invitation to come here today. I can see my slides right there, and I can advance them with the green button, I'm guessing? Yep. Perfect. Sorry, I'm on call, so I just kind of rushed in and then rushed out. Somehow I took this weekend off, but I ended up on call somehow because Dr. Chu was in Toronto for a little bit, and Dr. Wang had to go somewhere, and Dr. Sapon had to go somewhere, so I'm doing CAR-T duties and cross-cancer duties today, so hopefully my device doesn't disobey Lorelei's strict rule of no device going off. Perfect. I hunch over too, I have very bad posture, so thank you for correcting. So I guess I'm not qualified to speak about myeloma here, so Lorelei asked me to talk about amyloid, So here we go, talking about amyloidosis, and really, what is amyloid is always the big question. So my big disclosure is that I never liked amyloid. It's always kind of one of those diseases that is a little bit harder to treat, and the therapies have never always been the best for this disease. And that's why we had this guy here at our site, Dr. Venner. He was our amyloid expert. He worked in the National Amyloid Center in London, England, and published the seminal therapies for this back in, I think, 2012 or 2013 in one of the big journals in hematology. So that makes it a thumbs up experience, I guess, when we had him here. But since his departure, we've been forced to deal with and confront amyloidosis as well. So just an outline of really the 3 W's and the H, what, why, where, and how do we treat this disease. So I'll try not to speak for an entire hour. I don't see a clock in the room anywhere, so just throw something at me if I start to talk too long. I stopped wearing a watch as well in this cell phone era, so I don't have any of those. But my children have recently just bought 2 watches, so they've been sleeping with them at night too and scratching their faces. Kids are great, aren't they? Amyloid, what exactly is it? Really, it's just this amorphous substance. When you look at it under the microscope, it kind of looks the color of this dance floor area, which I'm sure you're going to be occupying in a few hours' time when all the festivities are done. And it just kind of fills and infiltrates things. It just gets in there and just, takes hold and just occupies space. Really, at the end of the day, that's what it is. My explanation for what amyloid is when I'm talking in the clinic is it's this substance which ends up acting like this magical mixture between yarn and Play-Doh. So yarn, because it weaves its way into the various tissues and just disrupts things, right? It has that ability to do that. And Play-Doh, because once, kids are done playing with Play-Doh, what happens to the Play-Doh? It sits there. And then does it ever go away? No. Does it break down? No. You end up throwing it away, but it just takes up space in the landfill forever and ever and ever. And this is what it does in the body. So it doesn't really go away. It just kind of sits there and hangs out and unfortunately disrupts things because your body recognizes it as being made by itself, so it doesn't get rid of it. It's not foreign. It's not a bacteria. It's not like cancer. So the immune system doesn't really get rid of it. So really, that's the problem with amyloid, is it just builds up over time. So why am I talking about amyloid at a myeloma meeting? Well, it can affect up to 30% of people with multiple myeloma. So hidden array, it could actually cause some problems in some folks. It can complicate your care as well. It's an exclusion factor from any clinical trials. So clinical trials are always, our ticket to tomorrow's therapy today, I always say, often getting it for free. I think our myeloma program saved the Cross Cancer at least about $7 million when we last looked at that data in 2020 or 2019. So this is money that taxpayers no longer have to pay for what is a standard of care for the Alberta, or people in Alberta here. And from a big picture question though, like where does it come from at the end of the day is always the big question we ask for amyloid. Why is it there, and where did it come from? So this is where you need an origin story, like a superhero type or a villain story, I guess. So Dr. Pilarski, I told her this when we were going on a conference once. I was, for my little ones, whenever I tell them a bedtime story at night, I'd always say, once upon a time, because it has to be a make-believe story at nighttime, in a galaxy far, far away. So this is my homage to Dr. Pilarski, who was one of our big researchers at the Cross Cancer, who discovered some of the high-risk genetic features in myeloma, trained a few seminal people in the field, Dr. Jonathan Keats, for example, all came from Edmonton, which was, the myeloma pace 25 years ago around the world. So with that magical combination of Dr. Belch and Dr. Pilarski. So amyloid origins, really, we have to know what type of amyloid we're dealing with. There's lots of subtypes there, different things can produce amyloid in the body. Injecting insulin in your body can make for a collection of amyloid in that spot, which is related to the insulin itself. So it's just sort of this body's reaction to things that are foreign to it. So you have to find out what exactly is making the amyloid. And there's so many subtypes possible. So many subtypes. This is just there not to be studied, but just to list out, that there's lots and lots of different subtypes here of amyloid. We're thinking about the first one there, that AL amyloid. L stands for light chain. So light chain is something that we look at in people with multiple myeloma as well. We don't see that much of the AH, very, very rare. But the thing that's starting to attract a lot of attention is in the middle there. It's called TTR. There's actually some new medications out for TTR amyloid, about 3 or 4 new medicines. It tends to affect the heart primarily, mostly in older men, sometimes kidneys. So these are things that can be disruptive. It causes the same symptoms, and we have a scan actually that can be used for TTR amyloid. So we work with a couple of cardiologists as our team here. I would say if you're living north of the river, North Saskatchewan for our Calgary counterparts, North Saskatchewan River here, you go see at the Royal Alex Hospital, Dr. Mark Benoit. And if you live south of the river, Dr. Anita Chan at the Mazankowski has been helpful. So they're our partners in crime from the cardiology standpoint. And really leading the way is the folks in Calgary with their amyloid setup that they've got going down there. So depending on where the amyloid is, it can affect it sticks to different organs really, and affects the different organs and infiltrates into those different organs. And we've seen, a whole bunch of these different types. The last one I saw was related to apolipoprotein. That's one of those things that helps carry cholesterol around in the body. So we had one of those cases. It somehow ended up in the kidney. So, and it was causing some kidney issues. So how it got there, why it develops, I don't think anyone knows just yet, but it is this reaction that the body has to it. So the biggest ones, the most common ones we end up seeing are the AL amyloid right there, as I mentioned, and the TTR. So 2 different types of TTR amyloid. There's the mutated one and the one that's kind of just there in the body. And this is the one that we see often in older men, often affecting their hearts, can affect the carpal tunnel about 3 years before they get there. And the difference between these two is that this mutated one is often seen in people who are around 50 years old. So if you're younger, that could be something you might see. And why do we look for it? Well, this can be inherited in families. So if you've got one person with it, it might be a good idea to screen other people in the family for it. And the neurologists all have these tests out there in their clinics. We send everyone for different neurologic testing. The cardiologists have these tests available, and we've linked in with the provincial genetics lab as well, so they're able to offer these tests as well. We're still not at the same number that we're doing. Calgary's doing more than Edmonton at this point, with roughly the same population. So certainly the word is out a bit more in Calgary than Edmonton, but it's one of those things that we're working together in our provincial amyloid group as well. So subtypes really do matter. So I'm going to focus a bit more on AL amyloid, if that's all right, because that's just what we end up seeing a bit more. And what we deal with at the Cross, we've kind of divided the line there. We don't see any more of the non-AL amyloid at this point in time, just because we're a bit too busy now. We're still looking for the next Dr. Venner, trying to grow them. They don't grow on trees per se, so we're still waiting for that one to percolate a little bit. And why do we think about plasma cells? Well, plasma cells make the AL amyloid, and plasma cell cancer is multiple myeloma. So that's why those two can be linked together. So what's a plasma cell? I would say this is a nice little picture, a cartoon of a plasma cell. This is a normal cell. You got the DNA material in the nucleus, and it's always eccentric. So on one side of it, because on the other side, it's a little bit lighter. And this is where you end up making all that wonderful protein in the body. Those proteins are antibodies, and that's what we end up measuring. Those M proteins or free light chains, they all come from this light part within the liquid portion of the cell called the cytoplasm. So another way of looking at it in real life, you can see a nice Prussian blue stain right there, and then the white part right around there, we call that a perinuclear Hoff, right around the nucleus, right there where the DNA is. And the DNA is nice and open. It is described as being a clock face in myeloma cells or plasma cells here. So that's what the plasma cell, a normal plasma cell, looks like in the body. And we do have normal plasma cells. Everyone does. They comprise up to 5% of the bone marrow. That's what makes your memory portion of your immune system. So what is a plasma cell and where does it fit in the immune system itself? Well, going way back up here to the stem cell, we're going down on the lymphoid side of things. We also have the myeloid. Myeloid ends up making red blood cells, platelets, and the infection-fighting cells, the first responders. And then the lymphoid side is often the part that helps out with viruses and helps out with the memory portion of the immune system. So lymph nodes are often right in between this stage, right over here, and this is where your lymphocytes end up maturing. And once they're fully mature, nice and wizened, I'll call them the professor of the immune system. They have their elbow patches and everything on their jackets. They're the ones that remember that one battle that they fought, and they end up fighting and producing the antibody against that one particular infection that they end up having that memory against. So in other words, the plasma cell is a fully mature B lymphocyte. The normal one you can see right there, very similar to the picture we saw before. And this is a cancerous looking one. This is a myelomatous one. You can see that the antibody ends up leaving that really the factory floor portion of the cell and ends up being just deposited in the liquid portion, and it turns at this nice pink color. It's called a flame cell. And you can see normally they're supposed to be the size of these other lymphocytes right here, but this one's real big. And it's big because it's a cancer cell. It's not acting the way it's supposed to. And their job really is to produce these M proteins or these antibodies against infections. So just to summarize all that in one slide here, in all the different lymph node areas in the body, you get your lymphocytes coming in, you get your bad guys coming in from your whatever cuts or infection or the bowel, you get your antigen or your foreign substance coming in. There's a battle royale in the lymph node, and then things come out fully mature. They set up shop in the bone marrow, and then they end up producing within the blood whatever protein that they're supposed to try to kill off and prevent any further infection. So those antibodies, I always take time just to mention some of these things just because we end up looking at these things every month. Why do we take blood from you? Well, every month, well, it's to look at all this stuff. It's really, really important. So the antibody itself, you can see there's this smaller portion here and then the longer portion right there, and it's symmetric, divided in half. Same thing on the other side, mirrored. There's two parts there. There's the big guy called the heavy chain and the little guy called the light chain. So the big guy, there's a whole bunch of different big guys out there. IgG is the most common, followed by IgA and then IgM, and very rarely IgD. So when you look at the M protein number, when you can see it on the AHS Connect system, when you're looking at the results, this is what we're looking at for most people. About 60–70% of people end up having M proteins that are, primarily IgG based. And the light chain itself, on the small side, there's two flavors. I always describe it, two flavors, kappa and lambda. And often it's kappa first, then lambda, because it comes first on the DNA molecule, and you have to actually get rid of that portion of the DNA molecule and start expressing the other part. That's just the way that these things learn and fight off infections. So they cut off the initial parts, and that's how they get the diversity within the immune system itself. And we detect it with all the different, all our favorite tests that we end up asking for people, the blood, the urine. I'm sorry about the urine tests. We always have to do it just to look for things. The next blood test called the serum-free kappa lambda light chain. And then the last one is the quantitative immunoglobulin value. When we look for that M protein, what are we looking at? Well, we're actually looking at this right here. So we stick the sample in the gel, and then we run electricity through it, and this is what it ends up looking like right there. So in lane A, we turn it on its side. In lane A, you can see that it's normal, but then in lane C, there's this abnormal guy right there, heavily staining. And that abnormal guy in lane C is the M spike, the M protein, the abnormal myelomatous protein that we end up monitoring over time. So that's what it looks like in the lab itself. And the lab folks are really good. If you've never had the lab folks at the meetings, they're always happy to talk. Dr. Matthew Este, clinical chemist, they've got some newer technologies out there, and they can actually do this through capillary electrophoresis. So I'm sure there might be one to maybe say, hey, what exactly are they doing in the lab? Because they keep all these samples too. They're stored because they have to go back and compare. So they used to have this whole filing cabinet full of everyone's information that we used to collect every month. The free light chain itself. So this is another way of looking at that antibody. And you can see there's the light chain on one side, and the red part is the part that's hidden because it's sandwiched in between. This is my son's favorite part of the sandwich, the meat. He just wants to get rid of everything else and just get the meat portion. So when you open it up and you take it out, the meat is exposed. How much meat is in there? What type of meat is it? We have to analyze it. And so that's what this assay really is doing. It's the deli counter check, I guess, of what's happening. So this helps you quantify the kappa or the lambda. Lambda likes to stick together. They buddy up. They're like Velcro. So that's why lambda can sometimes be a little bit lower than kappa, especially in people with kidney dysfunction. Because in kidney dysfunction, this is where you get rid of this stuff. This is a picture of the filtration portion of the kidney. So kappa ends up building up a little bit over time. So that's why your kappa numbers can be up a little bit. Seeing all the referrals for all of the people with these proteins that we get in the Edmonton zone and north, we probably get about 5 to 10 referrals every week just asking about free light chain abnormalities that are just a variant of normal. And the people in Iceland have done a really good job. They've managed to, look at about 80,000 people within their population, which is a large chunk of the Icelandic population. And they've just done all these tests on everyone just to see, hey, what's normal, what's not normal? How many people have myeloma, precursor myeloma? So they're coming out with really interesting data now that it's about 5 to 6 years out. So we had a very interesting evening. We were competing for the same table at the bar at the Los Angeles meeting with the Icelandic folks, and then they said, "Hey, you guys are from Canada. We love Gimli, Manitoba." Apparently, it's a big thing in Iceland. They have a Gimli house within their national university in Iceland, because their Nobel Prize winner in literature wrote about Gimli as sort of this surrogate and sort of a surrogate for the hopelessness of life or something like this. So it was this really interesting thing. I don't know, but all the Icelandic people wanted to visit Gimli, Manitoba. And there's a large population of people from Icelandic descent there. So if we ever bring anyone there, that's the first thing that they're going to want to ask for. Why do we think about Gimli in Edmonton? There was a plane, I think, that took off from Edmonton and then was forced to land in Gimli, Manitoba once. I can't remember when it was, maybe in the 80s sometime. So Gimli, very important, very important.
Can I just ask, is there a higher percentage of people in Iceland that have myeloma that they study there, or it happens to be there?
Well, they had the right people to organize the study, and it's a very self-contained population. So your question is a good one. Is it higher in Iceland where, they have to have an app on the phone to make sure that the person that they're having a date with is not related to them by some means, right? So it's a very, very small population there that's self-contained. Is it higher in that very homogeneous population versus a more heterogeneous population we have in Canada or Alberta, where we have people from all around the world living here? We don't know the answer to that, and that's one of the potential flaws for that type of study, but it gives us a nice baseline value for one set population, and it's really changed the way we think about the light chain, because the normal values have radically altered, and the normal range used to go up to about 25, and so they've increased that to about 150 now. So not too worried about a lot more people, especially those with kidney dysfunction. That's what they've looked at. So I'm getting a lot more information from them as time goes on, and they're finding out lots of other information, like the percentage of 75-year-old men in their population that have smoldering myeloma is 1%, but you have to wait until you're 90 years old if you're a woman. Then it's 1% of the 90-year-old population that is smoldering, and it's creeping up every year until then. So interesting little tidbits of information when they're starting to look at population-based screening. That's probably the best data set that we're going to have. Why is that important? Well, as we start to get into preventative strategies for myeloma, now that there's going to be data presented this year at the big hematology conference in December on prevention of myeloma. So that's going to be a big thing, I think. How do we do that? And how do we capture that in the population? Because you have to start thinking now of population costs as well. What is the cost of this assay? And what is the cost of the drug? And is it worthwhile from a societal standpoint, or is it just worthwhile from a financial standpoint to just, wait for the disease to be there and then start treating people? Is sort of those population-based decisions that people in population health have to calculate. And then they get those, and then they try to ask the drug companies to negotiate down the price of their drugs and of the very expensive assays as well. Each one of these costs like $80. We had it down a lot more, but then the company that made the free light chain assay actually changed the fluid and changed the table that they did it on, the actual machine, and it drove up our costs by 2/3 here. So unfortunately, we're at the whim of whoever is controlling those two pieces of the infrastructure. So the monoclonal protein that we have here, as we said, very common, and this is data that's not taken from Iceland, but taken from Olmsted County, near the Mayo Clinic. And this is the other big population-based study that we have. Lots of New England Journal publications out of this. Very long-standing now, I think 40-year database that Dr. Kyle, who's still alive, not practicing clinical medicine at age, I think 92, but still going to all the research meetings. Very interesting chap. He was last in Edmonton in 2018, I think, with the clinical chemists. still very active and wanted to go to Churchill, Manitoba to see the polar bears, was his big thing that he was talking about then. So the M protein is really the paraprotein, the M protein. It's the thing that's being produced by these abnormal plasma cells. So lots of people end up having this MUGUS, this smoldering myeloma precursor to the myeloma itself, but really we're talking about amyloid. So amyloid can be there from multiple myeloma within people with it, or people with this MGUS as well can have this amyloid character. So that's why it's of importance, and that's why I still like looking at all the monoclonal protein consults that we get just to screen for amyloid, I think is the big thing. I tell all my residents and trainees, it takes like 30 seconds to diagnose multiple myeloma. It's very obvious when you see and have the right tests done, but amyloid is a bit more subtle. It takes a little bit more nuance, and that's where you spend the vast majority of the time asking questions about it. So, once again, where does it all come from is the big question. So when you have your plasma cell producing these antibodies that I just sort of outlined, the amyloid itself is the waste product that comes from the actual plasma cell. Any factory can't just produce, t-shirts. It has to produce waste as well. So that's what amyloid is in my mind. That's my thumbs down approach to amyloid initially. So I'm sure Dr. Venner would say it's the actual major production of the cell itself, but his thumbs up. So thinking back, it's the waste product. It's like yarn. It's like yarn and like Play-Doh, just to summarize that. And this kind of breaks down the feel. There we go. This breaks down the percentage of what we end up seeing. This AL amyloid right there. Maybe now that we're seeing a lot more people looking for TTR, this percentage is coming up quite a bit. And our AL amyloid is probably down to about 30% or 40% of all the amyloids that we're seeing now. And lots of different manifestations of amyloid as well that you just have to look out for. And this is why when I first meet everyone, I ask them to stick their tongue out at me just to see, is there amyloid involved? Because you end up getting a big tongue and you end up getting these ridges around the outside of it. And people say, yeah, I just kind of bite my tongue a bit more. It's getting in the way. Last time I had a positive hit on this particular question was on Thursday at the new patient clinic. So we still see people that end up having this disease. That's the liver. Okay, just in case you're wondering, that's the liver. Carpal tunnel is the big thing that we think of. And then all these bruises that we end up seeing in some folks because it can affect the clotting factors. And because it's weaving its way into tissue, the tissue itself gets a little bit more fragile. So you can potentially, damage yourself a little bit more easily. So lots of different spots in the body that this can work its way through. And I'm going to go through this a few different ways. So when you have amyloid, amyloid is just the way that protein is folded. There's two different ways of folding a protein, kind of an alpha way of doing it and a beta way of doing it. If you do it the non-AL amyloid way, it ends up going into the brain and it ends up causing Alzheimer's. So when you look up all amyloid on the internet, you're going to get a lot of hits on Alzheimer's and dementia, because that's what we end up seeing in the brain itself. That's not the type of amyloid we see and we treat for AL amyloid. It's folded the other way. So what do you mean by folded? Well, if you look at your hands, they're the same hands for most of us on both sides, but your thumb is on one side on either hand. So that means it's kind of folded the other way. And that's what gives it different properties, so to speak, from a stereotactic standpoint, or just the way that it's sort of configured in 3D architecture. It can affect the eye, but so can all of our medications. We worry most about the cardiovascular issues, the heart itself, because this is probably the one organ that it can affect the most and really affects people's lifespan the most. This is where we say it affects mortality the highest. And in the olden days, we used to say that if you had heart manifestations of amyloid, your chance of dying within 6 months is pretty good. Now that we have better treatments, not seeing as much of that early mortality or early death. But I've had people, get strokes because the amyloid is getting into the tissue and it affects the inner lining of the heart, makes it a bit rougher. So people can have strokes before they end up starting any treatments. The amyloid just gets in the way of the conduction system. So if everyone thinks of the lighting infrastructure here, if we end up going to the wall unit and stretching out all of the wires, infiltrating into the wires and stretching it out, well, the lights aren't going to work properly. Those might start to flicker a little bit because things are displaced and pushed and pulled. And that's the same thing that happens to your conduction system in your heart. Things don't work properly, the heart doesn't quite beat appropriately, and you get these arrhythmias. You get instead of the lub-dub of the heart, it goes lub, lub-dub, lub, lub-dub, lub, 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 right? It can go into different patterns. On the top of the heart, it causes something called atrial fibrillation, which can also lead to strokes. In the bottom portion, it leads to ventricular issues. So whenever you see anything exciting on a doctor show on TV, it's usually a ventricular issue. They're pounding on chests and cracking things open and massaging hearts. That's what happens when the bottom portion of the heart starts to dance funny and doesn't pump things properly. And that's unfortunately has a high association with dying at that point. The stomach, another one. If it's stomach up, it normally causes nausea. Stomach down, it usually causes diarrhea, often very bloody diarrhea, because you're getting into the lining of the stomach and the bowel itself. So people end up shedding the layers within their bowel wall, so which is not a nice thing. The nerves can be involved also, and the nerves help wire the stomach area, so it can lead to constipation as well as diarrhea. So that's always an interesting thing. You have to figure that one out sometimes. So the constipation is like the worst constipation ever. Things are just stuck. Those wiring is dead and it doesn't work properly. Very similar to what happens in people with diabetes, where the wires don't work properly. If people have had certain chemotherapies, ones like we call vincristine, I don't think anyone here has had VAD chemotherapy. We used to use VAD quite a bit in multiple myeloma. The V in VAD was always bad and made people mad because they couldn't feel anything after, and because it really blocked off and caused a lot of constipation there. So, but it ends up causing just this horrendous numbness within the fingertips as well. And it often is painful because you can feel it. They call it a lancinating pain. So it feels, I describe it as lightning bolts, kind of pain. So that's the type of neuropathy, the nerve damage that people can get in addition to the carpal tunnel syndrome, right? So that's where you have your thumb, first finger, second finger, and they're kind of numbish. The pinky still works all right, and then half of this finger right here, the second last one, the inner portion is numb, but the outer portion is not. And just the way that the nerves, architecture of the nerves go in, has to pass through the carpal tunnel itself, but the one that does the pinky in the outer portion of your finger, it bypasses it over the top of it. So if you end up clogging off that little, underpass that they have there, and then that ends up squeezing and it ends up compressing and it ends up causing problems. That's carpal tunnel syndrome. So we often send people off for EMG studies. In the city here, I've been sending everyone close by to the Glenrose. They've been really good and very helpful for us, getting people in really fast. But the carpal tunnel syndrome is something really of interest. We see a lot of referrals from the kidney doctors because they see everyone with kidney dysfunction. If you have some protein in your urine, that's the big thing that we end up seeing. Unfortunately, we end up having to biopsy a lot of the organs involved. So that's where we end up seeing the amyloid, and that's part of our struggle, is just trying to get the sample to look at adequately. The last portion here is the autonomic nervous system. That's the part that keeps your blood pressure going. When you stand up and you feel dizzy as you get older, that's just what happens because the autonomic nervous system doesn't quite work as well as it did when you were 20. Well, nothing really works quite as well as when you're 20. But that dizziness is part of it, and a lot of other, antidepressants and a lot of other medications can cause problems with this portion. Gravol makes you dizzy when you stand up sometimes. So that's one thing we end up just looking out for. The We call it postural hypotension. So you get low blood pressure when you first stand up. This can be devastating, right? We had a young woman who was 50 years old, I remember, and flying around the world doing her job, but she couldn't do it because she spent 9 months in bed because she had this horrendous, 50, 60 point drop in her blood pressure every time we used to raise the head of the bed up by 40 points. So we're lucky we have a very good neurology unit here within Edmonton. We have a residency program, so they do all the different tests. So they do what's called a tilt table test, where they take your blood pressure at this angle, and they put you up a little bit, they take your blood pressure, and they kind of see what angle it starts to go off at. So most of these people with autonomic dysfunction, they can't even get their head of their bed up 20% before they start passing out and losing consciousness, which is not the way you live life. So amyloid, a lot of people takes, sometimes 2 years to find the diagnosis, and they have to go through on average 3 different physicians to find the answers. You can see this was a study that was done back in 2015, and they just looked to see, where was the diagnosis made? What was the visits that people made before they ended up seeing, an amyloid person? And the first visit is often to the family doctor there. Some people end up just seeing other folks. The amount of hematologists there, not that much, but you can see it goes higher and higher as you go along. But this makes sense. The first step, you see your family doctor, something's wrong. Something's wrong with one of your organs. You go see a specialist of some sort, and then they poke whatever organ is involved, and you end up seeing the right person after that, or maybe after that. So it ends up being a bit of a slow process just because we were waiting for tests to be organized, biopsies to come back. The lab has to get the biopsy sample right as well. So, and there's been a lot of struggle with that. We've had to really work with the lab people, and I think finally we're sending stuff off and getting results back before 2 to 3 months. It took a long time to do that. It took about 7 years of my life to get that organized.
Can I just ask a quick question? I usually don't freak out about anything or stress too much about life in general, but I have a lot of the symptoms that in the previous slide. My question is, once you've been diagnosed with myeloma and we do our monthly blood work, right, just to check on light chains and M proteins, are they looking for amyloid at all, like during our routine, or do we just get complacent?
Sometimes you just, once you're on the train, you're kind of on the train, so to speak. So that's one side, but you're in the right spot for amyloid, especially in Calgary with Dr. Zepeda there. I have had people with subsequent relapses come up with diagnoses of amyloid, because it depends on what clone ends up coming back. Because they say on average, when you're first diagnosed, you have 5 different clones that could potentially lead to myeloma or amyloid of these plasma cells. And when the disease comes back, is it the original one coming back, or is it one of the smaller ones that were there? There was a big study they did, and they found that, switching gears to leukemia, the leukemia that people end up being diagnosed with at age 60, 70, 80, when was it first seen in people? Well, it's first seen at age 40, very small. And this is the job of the immune system. It's to contain these things. As soon as you hit age 40, all of these clones are probably in there. The MGUS clone, the one that's going to turn into the myeloma, the one that's going to turn into leukemia in the future. But you have to have the right conditions within the bone marrow to allow that to grow. That's an immune system hit and probably a bone marrow hit as well. So you have to have the right environmental factors to lead to it as well. So just because it's there doesn't mean it's always going to come out in someone as well. But we can detect the earliest formulations of it in most people around age 40 for some reason. So I was wrong. Life doesn't go downhill at age 20, it goes downhill at age 40 instead. But the symptoms of amyloid are also fairly similar to side effects from the drugs that we get too. So that's the hard part. We have had people, not that common, but when they are diagnosed with relapses of myeloma, the myeloma relapse is actually one with amyloid being produced as well. And sometimes I don't want to know the answer if there's amyloid there, because then I can't get people onto their clinical trial, which will exclude them. And whatever is good for the myeloma clone is going to be good for the amyloid clone as well. The biggest thing I find when looking at amyloid is your sensitivity to dexamethasone. So people with amyloid can't tolerate the dexamethasone at all, and then end up getting a lot of swelling and fluid issues, much more so than the average person. And that's ends up being sort of my diagnostic test of choice, really, because we're throwing 5 tablets, 10 tablets of dexamethasone, especially when the disease comes back for the first time. And everyone gets flushing in the face and the energy high and the energy crash after. But if you end up gaining about 5 kilos of fluid, then you probably have amyloid at that point. And that's when we would probably know for certain. But it's always a good thing to, always ask the question, what type of myeloma are we dealing with here? And is there amyloid there as well? So it's one of those screening things that we can look at. If one did have amyloid and it progressed, it would probably continue to progress, and it's hard to live with amyloid deposition for probably more than 5 to 10 years, and because it just ends up infiltrating in and causing a lot of problems. So chances are probably not from the beginning, but it could come up over time. What time is it? Just while we 13 minutes. Oh, that's fine. No, we're good. We're good. So just a picture of the heart here, just showing how thick it is. Normally the heart, this hole in the heart here normally goes out to this white part, so you can just see how thickened the heart is here. Otherwise, whenever I see ultrasounds, I always ask where the baby is. I can't see any babies in here, but this is one of the modalities that we really use quite a lot of, the echocardiogram, to look at heart issues. The other one is MRIs. Hard to get an MRI really quickly. I can't order one. If I order one, it takes a year to get. That's why I need to work with one of the cardiologists to try to work behind the scenes to get things organized for us. So that's why you have to have partners. So lots of amyloid symptoms. I kind of went through this all already. That's why we look at the urine so closely. Dr. Kyle always says, need to do that 24-hour urine collection at the beginning just to look and quantify the albumin there, not just the light chains, but the albumin, to look for the amyloid. So that's why you always want to do that. We end up looking at things like cardiac enzymes as well. So how do you treat it? Amyloid is a team sport, so there's got to be a lot of folks involved, not just us for the AL amyloid, but also we need some help from the organ doctors, whatever organ is involved as well, and lots of supportive care. So I was just going to go through all the organs. I think I kind of talked about a lot of this stuff already. The big thing with heart is you can have devices that we can insert into hearts to help prevent the sudden death. But unfortunately with amyloid, if the heart gets too thick, normally we start worrying about it if the heart is about 1.2 centimeters thick in the middle. It should be about 0.8 centimeters, but if it's 1.2 centimeters, you start wondering about it. If it gets to about 1.8 centimeters, the actual electrical current that you stick into the device going into the middle, the current can't actually reach the walls that it's supposed to. It only, goes about 0.8 millimeters on one way and the other way. So it physically can't send the electricity to where it needs to and contract the heart or prevent the abnormal beating of the hearts that this can cause. So there is a limit to even some of the devices we have. It's no good if we're cooking the heart at the same time. So that doesn't work unless you're at that Brazilian steakhouse where they bring you the chicken hearts. And those are not bad. We try to avoid medicines like digoxin because digoxin is linked with higher mortality. And unfortunately, other things like the Velcade that we use in people is also linked with higher mortality as well. So often when starting the Velcade or bortezomib injections in people with heavily infiltrated amyloid heart, the mortality can be as high as 50% in a year, in a month, I should say, in 1 month. And the average mortality is 6 months with this disease. So the question is always, do I end up treating it? Because you could potentially do more harm than good. Because I don't want to write the chemo that's going to kill someone at home with the sudden cardiac arrest, which has happened far too much in my life. And even if it happens inside the hospital, I've had one person pass away. He was a former athlete who played on the Golden Bears hockey team. He passed away within the Mazankowski Institute of cardiac death from amyloid on a subsequent relapse from his myeloma. So, sometimes if the heart stops, and you just can't get it back. So that's why we're always trying to think about it. The liver itself, this stuff infiltrates into the liver, can cause big livers. So we look at a test called the alkaline phosphatase. And if there's a big liver, there's just lots and lots of amyloid there. And the big thing that we think about with liver involvement is that the amyloid clotting the clotting factors in the body stick to the amyloid, physically stick to that piece of yarn that's in there. And it can lead to clotting disorders, bleeding disorders. And if the liver, which is now fairly firm as well with all this amyloid in there, it can physically crack. And then if it cracks and you have a bleeding disorder with it, all the blood, you can get 4 liters of blood in the abdomen then. And then people often end up going to the intensive care unit. Being the liver transplant center for Western Canada, we end up seeing probably about 1 person every 2 to 3 years with amyloid liver. And this is always the question, can we transplant the liver here in this case? What's the chance of recovery? How do we get this better? So it's a question that still comes up. And when we see a little bit more of here with our organ transplantation expertise here. In the stomach, I kind of talked a bit about this. One thing, we used to use the rectum for biopsy sites. We don't really use it anymore, but if you're seeing someone that hasn't been reading their data recently, you might get approached for a rectal biopsy, and it's really looking for this. We can actually just use soft tissue, so just take a fatty portion off of someone. The nerves, I talked about the nerve pain, the carpal tunnel, the dizziness, and the constipation. For the organs, really, we're looking at bubbly urine. If you're, going to the bathroom, flushing the toilet, and the bubbles don't go away, that's when we start thinking about this healthy protein, this albumin that's there. The skin, sometimes it can lead to a little bit of a rash. It has to be biopsied and really have to look at it. In the lungs, when we see amyloid in the lungs, it's not associated with myeloma, it's associated with a lymphoma actually. So I have a large collection of people. I've probably diagnosed about 15 or 20 people with this. And I've only treated 2. We end up just watching it with the lung doctors. So it's a different sort of beast that's there. And also with the lungs going a little bit higher up, but different, is the vocal cords. So I've had people say that, since being diagnosed, my singing voice has gone away. I've never had a singing voice, but people tell me this, that the singing voice it gets more hoarse and cracked. So this could be from amyloid infiltration there. So you just need a camera to go in and look at the vocal cords. And really, we want to make sure that those vocal cords don't get so thick that they're permanently closed and there's no space, because then you can't breathe. So we have to shave off part of the vocal cords in this case. So Dr. Allegretto here, he's the voice person in Northern Alberta, so he does all of that work for us. And it's not the type of hoarse voice you get from the dexamethasone either, so don't worry about that. It's one that's there and it persists. So how do we treat it? The old combination of cyclophosphamide, dexamethasone, Velcade, what a lot of people had received here before we had funding for our daratumumab up front for multiple myeloma before October 2022. This is what everyone got. So we end up using this combination for 6 total cycles, 24 doses once a week. Unfortunately, this was really good at stopping production of the amyloid protein, but what you got to do is you got to try to make the organs better. This only made the organs better about 10% of the time. Didn't do a good enough job of clearing things out. If we did, get rid of all the production of the amyloid there, and making that free light chain, trying to make the difference between the kappa and the lambda. It's often lambda as well, it's 80% of the time lambda. If we can make that difference go within 40 of each other, that's the big thing. And the disease tends not to come back then for about 7 years for primary amyloid, which is good. And sometimes over time, the organs do work and try to get a little bit better, but it's still only 10, 15%. So really, you've got to make sure that you're stopping the production and trying to remove this as well, remove some of the amyloid. And this is the big thing. You still need to be able to remove the waste that's there. And this is where the added benefit of daratumumab comes in. It's a limited duration daratumumab in the Andromeda phase 3 study, only 24 months, 2 years, as opposed to the lifelong ongoing daratumumab we have for myeloma. Why the difference? Well, because there's far fewer often plasma cells in amyloid, so we don't have to worry about it as much. They don't have that same drive to grow and divide. They're making an abnormal protein, but they don't necessarily have an abnormal growth rate. So that's why they thought 2 years was good. Really, it helps stop production up from 70% up to more than 90%. And it boosts the organ response at 3 years to 50% almost. At this year at the big hematology meeting in December, we're going to find out the 7-year rate of what the amyloid clearance is from the organs. And I'm really interested if it is above 50%. So we've had lots of people. So we'll find out. We will find out. All the other therapies, really anything that we use for multiple myeloma can be used for amyloid. You have to be very careful with doses, especially the dexamethasone. Cardiac heart issues with the carfilzomib, always have to watch out. There's limited data on selinexor. Dr. Zepeda in Calgary loves belamaf, our BCMA antibody that can affect the eyes. Not really too much data on that one, but he really likes it, and I think the Australian group was working on that one. And there's going to be some more on the bispecific class as well coming out. There's some clinical trials coming out in this area on the teclistamab sort of idea, elirantinab. The company that's studying it is AbbVie, so it's ABV383, I think is the name of the molecule. So we're waiting for that clinical study to come out. Other trials are involving these BCL2 inhibitors, inhibitolas. Ooh, my apologies. My son fell asleep on me on my lap yesterday while I was doing this, so I obviously typed something wrong there. The big thing we look out for from a chromosome standpoint is chromosome 11 and 14 fusion. So that's what we are looking for, because there might be some sensitivity to these BCL2 inhibitors like venetoclax, which has got some data in multiple myeloma. And it's generating some data in amyloid, and there's about 2 other molecules very similar, sonetoclax and another one that's in clinical trials right now. So they are looking at it specifically in amyloid. So we do look out for this because sometimes the cyclophosphamide works really well in these guys and the Velcade doesn't. So for some reason, there might be some more sensitivity to the alkylator-based therapies. Can we transplant people with bone marrow transplant? Certainly, but we end up getting a very high death rate if 3 organs are involved. Like we're talking 30% mortality rates at 30 days. That's not good. I don't want to kill someone with my transplant. That's not what we want to do. So that's why we avoid it if at all possible. Where the transplant fits in with the new daratumumab era, we don't know the answer, and there's a clinical trial asking that question. If someone can just get daratumumab-based treatments, do you need a transplant or no transplant? So we'll end up getting some data probably in, 4 years' time or 5 years' time. It's slowly accruing clinical trial. So there, I think I've taken up enough of your time. So that was my presentation. So if there's any if there's any questions, I'm happy to have those.
If you have any questions, just please raise your hand and I'll come to you with a microphone so everybody can hear. Yeah. Any questions from the room?
I know you've already addressed this issue, but I didn't quite grasp the answer. So if I'm asking you to repeat, my apologies, but so the amyloid, is it detectable just by blood work or is it only by biopsy?
Detectable only by biopsy. Yeah.
Okay, thank you.
Any other questions? No, do we have any virtual questions, Chantal? Okay, so it looks like we're on time for our break. We do have 15 minutes for the break, and we'll be back at 10:45 for the next presentation. Thank you.
Thank you.